Hello, my name is Thomas Piraino. I'm the clinical specialist for mechanical ventilation at St. Michael's Hospital in Toronto for the Center of Excellence in Mechanical Ventilation. I'm also a lecturer adjunct for the Department of Anesthesia, Division of Critical Care at McMaster University. And I'm here to talk to you about COVID-19 considerations for the management of acute respiratory failure. My disclosures are that I have received payment for speaking and consulting from Drager, Fisher & Paykel, and Phillips, however not related to this talk. The presentation is supported by the Canadian Society of Respiratory Therapists. I'm going to discuss current guidelines related to respiratory management of COVID-19 patients. I will describe the more recent discussions about COVID-19 management that are now popping up in the literature. I will describe the Center of Excellence in Mechanical Ventilation, or COEMV, approach to managing ARDS patients. I will discuss adjustments we've made to our internal process in order to facilitate increased workload due to COVID-19 patients, and describe the challenges of weaning COVID-19 patients in particular and tools for assessing excessive effort in all patients. Then I will describe the COEMV approach to ventilator liberation. The first truly evidence-based guidelines that were released for the management of critically ill adults with coronavirus disease 2019 were the Surviving Sepsis Campaign guidelines in association with the Society of Critical Care Medicine. I'm going to review the recommendations that are specific to respiratory therapy practice. So let's start with non-invasive respiratory support, specifically supplemental oxygen, high-flow nasal cannula, and non-invasive ventilation. So the recommendation for giving supplemental oxygen is to keep saturations between 90% and 96%. High-flow nasal cannula is recommended when hypoxia persists despite conventional therapy. And then they recommend a trial of non-invasive ventilation if high-flow nasal cannula is not available. And they recommend overall close monitoring and early intubation when patients have signs of failure. Now, the reason non-invasive ventilation is not recommended for COVID-19 is due to the fact that it fits the two categories that have no recommendations currently in our guidelines for adult non-invasive ventilation. The reason there are no guidelines in these two categories is because there's either mixed data of success and or failure, or there's limited data. So de novo respiratory failure is respiratory failure unrelated to chronic respiratory or cardiac disease, and of course pandemic viral illness fits very well with what we're dealing with COVID-19. And there's not a recommendation to not do it, and there's not a recommendation to do it. So providing or not providing non-invasive ventilation, there really is no recommendation. Therefore, it's not a strong recommendation in the guidelines or even a first line recommendation. Now, I'd like to take a moment just to address an ongoing, I would say, confusion in the literature. The word dispersion and the word aerosol generation or aerosol generating medical procedure. There's a lot of discussion right now in the literature that have sort of pegged high flow nasal cannula as this beast of an aerosol generator, but without actual good evidence to suggest that it creates aerosols, rather than just provides flow and disperses droplets and aerosols that may be present. And so we need to understand the difference between these two categories. So aerosol and dispersion are different. Dispersion is the distance that exhaled air can be dispersed by these devices. And as you can see, the range is all the way up to 100 centimeters and down as low as less than 10 centimeters. The devices are not created equal, but to single out, for example, some hospitals are refusing to use high-flow nasal cannula, but the evidence of dispersion is not there. And the aerosol generation evidence is very confusing because some of these studies of dispersion were introducing an aerosol and seeing how far the aerosol was dispersed. But of course, that doesn't mean that the device itself creates or generates it. For that, we need a different kind of study, which I'll explain in the next slide. So at the time of this recording, this paper was published this week on April 20th, 2020. Now, it was published online ahead of print and ahead of peer review. So I just want to point that out. This paper at the time of me discussing this was going through peer review right now. But many studies right now, because of the context and the time we are living in, many people are trying to do rapid publication of very interesting information that can help guide either guideline generation or therapy options, etc. So what they did was they looked to see if aerosol production actually occurred with different oxygen therapy devices. Again, because dispersion has already been recorded, and reported in studies the dispersion distance, and many of these studies would add aerosol to the mix and then it would be dispersed. But does the device itself generate the aerosols? And they found they took healthy human volunteers and there was no evidence of increased aerosolization, whether it was nasal cannula, non-rebreather, or heated high flow nasal cannula. So these devices do not generate aerosols. They disperse them if they are present, but they don't generate them. And we know that heated high flow nasal cannula uses vaporized humidity. It's not a nebulized humidity. So nebulizers, of course, create droplets and aerosols. They're nebulizers. That's what they do. They break up particles. But the heated humidity coming from high flow nasal cannula, for example, is just vapor humidity, and it does not generate an aerosol. Now, a brief note about CPAP, because many places around the world are using continuous positive airway pressure. So it has been used as a first-line therapy in many organizations. Some reserve it for patients with evidence of lung edema only, and that's measured based on ultrasound or CT or chest x-ray. It is commonly used as a sealing therapy. So if a patient does not want to be intubated, they will give oxygen therapy, and if the patient is still working, they will provide CPAP as the maximum therapy they're going to provide prior to withdrawal of life support if it gets to that. So it is considered a sealing therapy for many. Now, if failure occurs, some of the reports we're hearing that if failure occurs days after non-invasive ventilatory support with CPAP or BiPAP, that these patients are more difficult to manage and they require longer duration of mechanical ventilation. So right now, we actually don't know what the best approach is without a proper study. There are some studies in certain patient populations where intubating early was no different than treating a patient for days and then they fail later. And in other studies, intubating a patient early, the patients had better outcomes than waiting and the patients failing later. So we have to understand that right now, because we're in the middle of a pandemic, we don't really know what the best approach is because it hasn't been properly studied. High flow nasal cannula has been used globally and we use it ourselves with good success. And some people have considered using something called a ROX index to predict failure of patients with COVID-19 receiving high flow nasal cannulas. So the ROX index was published in 2019. It takes your SpO2 divided by FiO2 and divides that by respiratory rate. And it's an index that at different time points will have a score that will predict a high risk of failure of high flow nasal cannula. And it has a value of, if it's greater than 4.88 at any time, the patient is considered a very low risk of failing high flow nasal cannula. So the only thing I want to caution with using that is that many people are reporting this happy hypoxemic patient. So a patient who doesn't seem to have a high respiratory drive may have, again, a very low denominator. So the patient may have a high ROX score, but may still be at risk of failing. And the score was really, it only really provided data for the first 24 hours. So it's important that if you are providing care for these patients for more than 24 hours, that you really should be monitoring close for changes in effort and mental status for any signs of deterioration. And our sort of threshold to consider intubation is when FiO2 requirements are 60% to maintain SATs of 90% in these patients. Another therapy being utilized with COVID-19 patients is prone positioning with high flow nasal cannula, or CPAP. Now, there was a recent study published, but it was not in COVID-19 patients, but it was published this year, that showed that it could be safe and effective in patients to avoid intubation. They do point out that patients with PF ratio less than 100 all required intubation. Now, we've asked our colleagues around the world, and they suggest that patients will tolerate between 2 and 4 hours of prone positioning, again, spontaneous prone positioning, but they warn us to be careful when the patients return to the supine position, because if you've weaned the FiO2 while they were prone, many of these patients will desaturate when they go supine, so just be prepared for that to happen. I just want to summarize that section by saying, outside of the context of a clinical trial, everything we are learning about the non-invasive respiratory support of COVID-19 patients is currently anecdotal. We don't know if the best solution is to intubate early and avoid prolonging non-invasive ventilation in the event that they'll eventually fail, or we don't know if there are certain markers or things that would tell us specifically that this patient who looks like they should be intubated is going to be just fine. We don't really know, so everything is a gamble. Intubating someone early, we know they're going to be complicated to manage on the ventilator, but their management may not take as long as it would if they failed 4 or 5 days later, and we have to consider this. We don't really know what the best solution is, and everything currently is anecdotal. Now let's talk about invasive ventilation and the ARDS management guidelines that were provided for COVID-19 patients. Let's first start by defining the Berlin definition of ARDS, which is the most recent definition of ARDS. And by definition, I mean it's really a list of checkboxes when you think about it. It's, did it happen within 1 week? Are there bilateral opacities? Is it not fully explained by effusions, lobar lung collapse, or nodules? And then, is the respiratory failure not explained by cardiac failure or fluid overload? Again, they prefer an objective assessment like echocardiography to exclude hydrostatic edema if there's no risk factor for that present. And then it comes down to the thing that most respiratory therapists focus on. Once someone says they have ARDS, we start to focus on the PF ratio and what we can do to improve the PF ratio. And of course, that is PaO2 divided by FiO2. And above 200, but less than or equal to 300, so technically 201 to 300 is mild, 101 to 200 is moderate, and then less than or equal to 100 is severe. Now, I do want to point out that many of the past studies that were published either just after this or before, because a study published, for example, in 2013, this study would have been probably finished in 2012 and published almost a year later. That's just the reality of research. So many studies published in 2013 or around there did not have this definition because it wasn't available when the study started. And what most people used for severe ARDS before all of this definition was less than or equal to 150 millimeters of mercury was labeled as severe ARDS. Again, that was with the lack of this definition. The Surviving Sepsis Campaign guidelines recommend tidal volumes of 4 to 8 mils per kilo. Now, this is not new. This is the same recommendation by the ATS guidelines as well for ARDS management. However, we should start at 6 and reserve 8 mils per kilogram of predicted body weight for patients that have persistent hypercapnia, that you've already increased the respiratory rate. So rather than pushing more and more dead space, you need to increase alveolar ventilation in some way, and again, using slightly higher tidal volume up to a maximum of 8 would be preferred in that situation, provided you can complete the next recommendation, which is keeping plateau pressure less than 30. Below that, we have moderate to severe ARDS. Use the higher PEEP strategy. And again, these 3 recommendations are based on strong quality of evidence. I'm going to talk more about the high PEEP strategy, and just keep in mind that many people over the years have thought that perhaps randomly applying any PEEP strategy to all patients may be injurious, but until now we don't know what the best approach is for individualizing PEEP. Having said that, right now would be a perfect opportunity to study this, and we plan on doing so in our institution with the multi-center study. Prone positioning for more than 12 hours is recommended, up to 16 hours. Intermittent bolus of neuromuscular blocking agents instead of continuous infusion when possible. However, if the patient has severe ventilatory asynchrony, ongoing need of deep sedation, regular prone positioning, or the plateau pressures are high, you can consider using a neuromuscular blocking agent infusion to facilitate lung protective ventilation. The rescue therapies that are recommended are the usual inhaled pulmonary vasodilators, recruitment maneuvers. They prefer sustained inflation over staircase, and then VV ECMO, again, all weak strength of evidence, but all considered rescue therapies when required. Now, I will only describe prone positioning in one slide. I won't go on too long because this deserves its own talk, but the current recommendations are for more than 12 hours of prone positioning, but we would consider everyone use 16 hours as a target because this is based on probably the best protocol so far for prone positioning, which was used in the ProSEVA study. There was a meta-analysis that found that using 8 mLs per kilogram or less of tidal volume, again based on predicted or ideal body weight, should be used. So lung protective ventilation tidal volumes and PF ratios less than or equal to 150. Now, how does prone positioning work? Well, you've got gravity working against you. This is supine and this is prone. And of course, while you're lying on your back, your pleural pressures are much more positive in the dorsal regions of your lung, and they are less positive or maybe even negative in the ventral part of the lung. And of course, this causes a lot of area of collapse. Now, this part of the lung, we have more tissue, and because you have more tissue, you have more perfusion. So by turning a patient over, you now have gravity still working this way, but now you've increased the pleural pressure in the ventral regions and you've decreased the pleural pressure in the dorsal regions of the lung, where you have more tissue, more perfusion, therefore better better VQ matching. So that's really the principle behind why prone positioning is being recommended for all these patients, because most of them are presenting with a great degree of hypoxemia, and despite the PEEP that you provide them, whether it's high versus low, etc., they respond to PEEP, but they still remain to be significantly hypoxemic, and that's what we're finding and most people around the globe are finding, which is why prone positioning has been such a strong recommendation. Again, a weak recommendation based on the evidence right now, but in terms of globally what's going on, many people are suggesting to prone patients when they are intubated and have developed this ARDS picture. Now, what's interesting and may surprise some people is that the strong recommendation for high PEEP is not based on any of the individual studies that compared high versus low PEEP. In fact, none of them showed a difference in mortality, both in hospital or in ICU. So alone, these studies did not show benefit high versus low PEEP, but in an independent patient meta-analysis published in 2010 in JAMA, what they found is that patients with ARDS, and that's specifically moderate to severe ARDS, because the patients listed here with mild ARDS, or it says without ARDS, but they are the mild ARDS patients that we would classify now. At the time, they were called acute lung injury, and it wasn't grouped into the category of ARDS, but these patients would be mild. And the patients with ARDS are the moderate to severe, so these ones here. And what they found is a reduction in mortality that was significant when using higher levels of PEEP, both in hospital mortality and in death in ICU. And when you look at the patients with mild ARDS, as I described, the patients with higher levels of PEEP had higher mortality in hospital, not quite significant, but looks like a trend. But in hospital, again, slightly higher mortality, but this was not significant. But definitely higher PEEP strategy in patients with mild ARDS is not recommended. The recommendation only applies to those with moderate to severe ARDS. Now, the purpose and benefit of PEEP is to maintain end expiratory lung volume and to prevent alveolar collapse and maintain good respiratory system compliance. Now, some of the considerations and risks of PEEP is that the pressure required to maintain the lung open is variable. There'll be areas that, in order to keep it open, you put other areas that are already open at greater risk of overdistension. So if the lung is not recruitable as well, overinflation of healthy tissue is almost always certain. PEEP can affect perfusion through the lung, and this may impede gas exchange, but it may also help in terms of your PaO2, and I'll describe that in a bit, but it can be very confusing how increasing PEEP may appear to be beneficial if you're only looking at the PaO2, but you're ignoring ventilation, so CO2. So PEEP can affect venous return and hemodynamic stability as well. Now, of course, the simplest approach for setting PEEP is using a PEEP FiO2 table. And these tables are very common around the globe because they have been used in many studies of ARDS. And of course, you have the low PEEP table, which is generally recommended for mild to moderate ARDS, and then the high PEEP FiO2 table, which is recommended for COVID-19 patients, or again, I should say higher PEEP is recommended, but when people say what is higher PEEP, they typically look at something like the high PEEP table, and it's reserved for moderate to severe ARDS patients. And of course, we need to understand that patients that are unresponsive to PEEP, there is a significant risk in using the excessive levels of PEEP, and typically this is shown in the presence of a plateau pressure that exceeds 30 when PEEP is too high. So this is why that limit of plateau pressure is in there, but of course this means that the PEEP tables can sometimes be challenging to use. For example, in the low PEEP table, we have 50% being used and a PEEP of 8 to 10. In the high PEEP table at 50%, we have a PEEP of 16 all the way up to 20. So the problem is that in many situations, the only way you're going to get a PEEP of 20 and keep a plateau pressure less than 30 is if your driving pressure was only 9 centimeters of water, which again, in moderate to severe ARDS is probably not that common. So typically what happens is you end up on PEEP levels around here with higher FiO2s. So even though the strategy is to use a higher PEEP strategy in patients, they end up getting capped sort of in this region right here, and then people will start using higher FiO2. So yes, this is higher PEEP than what would be used, here, but in terms of what people are looking for when they look at high PEEP, they look at the high PEEP table, but let's look at some studies to see whether or not high PEEP is being used. So this is some information from the ROSE trial, which was published in New England Journal of Medicine in 2019, and it was a neuromuscular blocking agent study in severe ARDS, and you can see the PF ratios here are quite severe. And as you can see, they're on 80% FiO2, and they were told to be using a high PEEP strategy in the paper. And you can see they end up with a PEEP of around 12.5 in both groups. So again, if this was the high PEEP table, they should technically be on a PEEP of 20. They have plateau pressures that are less than 30. So technically the PEEP should be higher, but it isn't. So high PEEP is generally somewhere around, who knows, 12 to 15, we're not quite sure. But when you look at the PEEP table, it technically should be around 15 or higher, because at 50% FiO2, you should already be on a PEEP of 15. But as you can see, it wasn't practiced in this example. Now here's some sobering data from the LungSafe study looking at practice. And if you look at patients treated with moderate to severe ARDS, you can see that the PEEP levels are 10 or less. So there's a lot of discussion about us using evidence-based practice and using higher PEEP levels, etc. But we don't typically do that globally. Now I know there are centers that use higher levels of PEEP, but they're not using PEEP levels that are within the range of the high PEEP FiO2 table. And having said that, there are many community hospitals that are now going to be required to look after these COVID-19 patients because they can't transfer them. And if they are looking for how to set PEEP in these patients, they may be finding the high PEEP table because high PEEP is recommended. And if they're using that and not really paying close attention to many other aspects of care, again, they may be providing excessive amounts of PEEP, and the patients may tolerate it and have a plateau less than 30 because their respiratory system compliance is higher in some patients. And we have seen this. We've seen patients with driving pressures 10 or less. And if the driving pressure is 10, you probably could get away with a significantly higher level of PEEP. But if the patient does not have PEEP potential for recruitment, or I should say doesn't have potential for recruitment with PEEP, then giving this high PEEP is likely injurious and could lead to problems. And one of these problems is the result of positive pressure on the right heart. So as you increase PEEP, of course, you get higher plateau pressure, and you end up increasing your risk for mortality, which is understood. But when you give pressure to a lung that perhaps doesn't know what to do with the pressure, you always have the possibility of affecting the right heart. And this is acute cor pulmonale, which is right heart failure, and you can see it's significantly higher as your plateau increases, as does your mortality. So there is this direct interaction with PEEP and the right heart, and we really should be cautious about how we, again, randomly apply PEEP. We should look for other interactions that may indicate that the PEEP that we are providing is too high. And what we are finding is that most patients, even without the potential to recruit, are responding to high PEEP. So oxygenation is improving despite there being no evidence of recruitment potential. And this we feel is something worth paying attention and something that worries us about the arbitrary setting of high PEEP in these patients. Now, one of the potential mechanisms for how PEEP could improve oxygenation, even though a lung is not recruitable, is when you have a significant amount of shunt. And this is described in this paper in Chest. If you increase PEEP and you were to reduce cardiac output, you will reduce shunt in most patients except this one over here. This is 12 patients. And as you can see, as PEEP is increased, 10 up to 20, you can see cardiac output is reduced and shunt sort of is reduced with it. So when you have a reduction in shunt, you could have an improvement in oxygenation of the blood. So you could have an increase in PaO2 despite there being no potential for recruitment. So this is one possible explanation as to why a patient with no recruitment potential could have their oxygen increase when they increase PEEP. And this is just something that we need to consider and think about, that we don't often as respiratory therapists think about cardiac output or shunt in patients. We just adjust PEEP typically because of a PaO2. So what should be considered a response to PEEP? And I really think that as respiratory therapists, we need to begin thinking beyond the PaO2. Just like I described, cardiac output's important, urine output's important. We need to think beyond the PaO2 and think what else are we affecting when we increase PEEP? And why do we keep chasing the PaO2? And the reason I say that is because very few ARDS patients die from refractory hypoxemia. So it's difficult to determine which of the outcomes we're looking at is the best surrogate for clinical outcomes. Oxygenation was worse in the intervention arm of the ARDSNet ARMA trial. This was the low tidal volume group. They had worse oxygenation, but they had a survival benefit. We see in studies of nitric oxide that they have improvements in oxygenation, but no mortality benefits. So everything seems to be opposite to what you would expect. and there was less refractory hypoxemia in the oscillate trial in the high frequency oscillation arm, but they had higher mortality. So we have a lot of controversial information not only from these randomized control trials, but also from observational studies. Now in 2006 in the New England Journal of Medicine, Luciano Gattinoni published a paper that discussed recruitment potential in patients with ARDS, and basically described that one of the things that is not typically assessed prior to assigning a PEEP strategy is whether or not the lung has potential to recruit. So it's quite a simple concept, but let me show you some of the CT scans that describe the differences that they observe and that they describe in their paper. In their paper, they describe patients with different percentages of potentially recruitable lung units. In the top, you have a patient with some alveolar collapse here, and when they increase the pressure from 5 to 45 centimeters of water, you still have the areas of collapse. So this patient has very low potential for recruitment. And the patient on the bottom, you can see there's much more collapse here, and on higher levels of pressure, again 45 centimeters of water of CPAP, there is significant areas of recruitment. So this patient has a higher potential for recruitment. Now what's interesting is this patient has higher levels of respiratory system compliance and higher levels of PF ratio that were significantly different than the group in the bottom. Now, let's move on to today. Fast forward to today, and we have a similar description for what's going on with COVID-19 patients. Those with less potential for recruitment and those with more potential for recruitment. And of course, these patients, it makes sense that they would have higher respiratory system compliance. These patients, it makes sense that they would have lower respiratory system compliance. Again, nothing different from what was described in 2006, except for one aspect. Both of these patients, when presenting, would probably be presenting with very severe hypoxemia. And we definitely have seen this, patients that regardless of their lung mechanics just have more severe hypoxemia than we typically see. However, because of this, they have described two different phenotypes. Luciano Gattinoni and colleagues have described two different types of phenotypes, and then they are now offering recommendations on how to treat these phenotypes, and this is upsetting a lot of the evidence-based practice community, and I'm going to describe things that we both agree with and things that we still question. And again, I mentioned that we like to individualize PEEP in our institution. I'll explain how we do that. We do look at the potential for recruitment, and we kind of disagree with some of the recommendations that they are giving, and I will explain them. So the phenotypes they are describing are phenotype L and phenotype H. Phenotype L has low elastance, low recruitability, limited PEEP response, and the prone response these patients have may likely be due to perfusion. Again, this is what they're describing. And on the right, we have patients with high lung elastance, high recruitability, higher PEEP response, and the prone response is likely due to recruitment of, again, this potential for recruitment. Now, the issue that both patients are having is this pulmonary microthrombosis, which tends to show up quite early. It's recognized. And the other issue is that phenotype L that they're describing, they say can transition to phenotype H. And what they're saying is that this could be the normal progression of the disease. We actually don't know because all this is anecdotal. Everything I'm telling you is anecdotal observations. But they're suggesting that maybe it could be due to how we ventilate the patients. So worsening ventilator-induced lung injury. And they're describing it in this group here. They're saying use lower PEEP rather than the recommended high PEEP. But the part that's being probably the most controversial for everyone is they're recommending higher tidal volume without really supplying a lot of evidence as to why. And they're suggesting levels up to 9 mils per kilogram of predicted body weight. Now, we do know that up to 8 is still considered lung protective, but we still should be using 6. And we think that we should only reserve 8 for patients that are severely hypercarbic and you need to improve or increase alveolar ventilation, provided your plateau can still be less than 30. But this is really the issue that's getting on a lot of people's nerves, is this recommendation without solid evidence to suggest why. Now, for the phenotype H, they're recommending high levels of PEEP and low tidal volume, which nobody has a problem with because that's exactly what's being recommended for these patients. So really the issue is with them classifying these patients and then suggesting how we should manage them. Now, one thing we can agree upon with these patients is that we think that recruitment potential is important. We've been using this in clinical practice for almost 5 years now. We assess the recruitment potential in patients prior to assigning whether or not they get higher or lower PEEP. However, it has not been tested in a randomized control trial, and we plan to do that. But it is currently our standard of practice. And the one thing we disagree on, and this was in our recent publication where we found patients, there are a number of patients that are considered recruitable, and those that are not considered recruitable, all of them had low respiratory system compliance. So we think that stratifying patients with high compliance versus low compliance is a little bit oversimplifying it. And even in our COVID-19 patients, we have found patients that when they transition from, let's say, from here to here, some of them will end up with low compliance, but not all of them become recruiters. So it's a little bit of an oversimplification. Again, not a lot of evidence to support it. It is anecdotal. It's upsetting a lot of people. But the one thing that I do feel is important, and this is why we're doing a randomized control trial. So I can't say I don't think it's important and then follow up with saying, by the way, we're doing a randomized control trial because we think it's important. But we think that assessing for recruitment potential is very important, and we plan to do that. And we hope to start our trial within the next week or so. Now I will describe the Center of Excellence in Mechanical Ventilation approach for managing ARDS patients and even our normal patients in the weaning phase. Now, this is how we traditionally treat our patients. This is not specifically the COVID-19 management, which I'll talk about how we've had to adjust some of this. But for our regular approach, for our ARDS patients, we fill out a form that's called an ARDS registry, and it has their transpulmonary pressure measurements. We assess for airway closure, recruitment to inflation ratio, and the ventilatory ratio. Some of the staff are calculating it now, but it's not on our form. It could be added, but it's also very easy to calculate after the fact. But some of our staff are using my online calculator to calculate this. It's very simple. We use electrical impedance tomography regularly in ARDS patients, and we prone patients when the PF ratio is 150 or less quite routinely. Now, weaning patients, whether it's ARDS or normal patients, we typically try to monitor P0.1, which we feel is a bit more important in patients recovering from ARDS because they can revert back to ARDS if their breathing is too intense. We do diaphragm ultrasound to measure thickening fraction, and we also use modes like PAV Plus or NAVA when we're having difficulty weaning patients. Again, this is our overall approach to managing patients. And now I'll talk about, in just a moment after describing the ARDS registry, I'll talk about some of the adjustments we've had to make to accommodate having many patients in isolation and proning. And again, there's a lot of workload with the staff. So here's an example of the first page of our ARDS registry, and it's been updated to have a little checkbox for suspected COVID-19. But as you can see, we capture a lot of data about the patient, so the gender, date of birth, the height, and then it calculates predicted body weight. We put in blood gas variables and their minute ventilation, and it calculates the PF ratio and a corrected minute ventilation value. There's some check boxes here for identification of the Berlin definition of ARDS. And then we put in all their vent settings, and for the respiratory system mechanics, we set the flow to 60 liters per minute. And we are calculating, with that, we are calculating driving pressure, respiratory system elastance, respiratory system compliance, and respiratory system resistance. On the second page, we are inserting esophageal balloons. Again, this is our typical management. I'll tell you how we've altered it for COVID-19 patients, but we are typically inserting esophageal balloons, doing a bunch of measurements, and more specifically, although we have the end expiratory transpulmonary pressure and the end inspiratory transpulmonary pressure, we're actually most interested in the elastance-derived transpulmonary pressure, and I'll tell you why in the following slide. And then we do what's called the response to PEEP. So we start at a clinical PEEP level. It could be anything, but typically if it's around 10, we'll start there. We do a blood gas, and we get all this information, their esophageal pressure, their systolic blood pressure. Again, we're trying to assess the response, and not just oxygenation, but again, ventilation for CO2, and of course, their blood pressure values. And then we increase the PEEP by 5 and draw a blood gas in about 10 minutes or so. And then we plot it all there, and so that we can visually see the difference between both PEEP levels. And then we check for recruitability. And this is what I was hinting at earlier when I said we should probably be assessing patients for the potential for recruitment and not just assume that someone's recruitable because of their respiratory system compliance. We really should measure it and assess it. But we check for airway opening pressure, which I'll talk about in a bit. And then we put in values of high PEEP, low PEEP, and I'll explain this whole maneuver in a moment, but we get something called an RI ratio, which I will describe shortly. But first, I will just describe why we look at the elastance-derived transpulmonary pressure. So at inspiration, the traditional method for looking at transpulmonary pressure, at least in two randomized controlled trials, is that you take the absolute values of airway minus esophageal during an inspiratory pause to assess lung stress that's being felt by the lung. But in this study, so there was a study done by Takeshi Yoshida looking at not just an animal model, but then a cadaver model that was embalmed with teal, which is it's a teal embalming method, which retains a lot of the elastic properties of the lungs. So it's actually very good for doing research related to lung mechanics, etc. So what they did is they placed pleural pressure sensors in the non-dependent region, which would be along the chest in a patient lying supine, and a dependent sensor, which is along the back, again, lying supine. And the transpulmonary pressure measured by an esophageal balloon is right here. And as you can see, it more closely reflects somewhere in the middle, but maybe even a little bit more so along the dorsal region. So the lung stress that it's representing, again, is somewhere in the middle. And what it's underestimating is the amount of stress felt in the front of the chest, which is typically the area still inflated. And I don't want to use the word healthy, but it's where your baby lung is. It's the area that's not necessarily affected in a patient who's supine with ARDS. Typically, it's the dorsal regions. So it's underestimating the stress in that region. And what they found is the elastance-derived method is this red line right here, which I'm going to circle in green. This red line closely reflects the stress being felt in the front of the chest. So in terms of our plateau pressure limits, we limit the transpulmonary pressure based on the elastance-derived method. So we will try to keep these pressures 22 to 24 at maximum. So ideally, less than 22 would be great. We wouldn't be worried at all. But if we want to optimize or like maximize someone's PEEP, this is as high as we would go, would be the value being between this range would be as high as we would go. So what is our simplified approach? Well, to make things easier, we actually still fill out everything here because these are just their vent settings and a blood gas. So we still do that entire part. But when it comes to the more complicated things, we are not trying to put esophageal balloons in all of our COVID-19 patients. They may get one, but if we have a large amount of patients, we're not going to be doing this on every patient. So we're actually skipping this part here, and we're even skipping this part here. And the only part we're doing for simplicity is doing the RI ratio and airway opening pressure, and that's our simplified method. But this I just explained as being something important, this elastance-derived transpulmonary pressure. So how do we rectify not knowing the safety of a plateau pressure limit? And we did this based on a number of patients from this registry form. We picked a plateau pressure that we are happy with, and I'll describe that next. So based on data from 204 patients, again, this is preliminary data, it's not yet published, but we looked at our registry data, and there was a significant distinction between patients when we looked at a plateau pressure of less than or equal to 28 or greater than 28. And the important thing is here's our limit of 22. Some studies have increased PEEP to a maximum of 25, again, of the elastance-derived transpulmonary pressure. That was their upper limit. And if we choose a plateau of 28, basically all of these patients are below that limit. So this is a very safe limit for plateau pressure, and ideally we are happy if the plateau pressure is less than 28 centimeters of water. Now, when we looked at 30 centimeters of water or less, we can see that there's still the majority of the patients are below our limit of 22. There's a couple that might be over 25, and anyone above 30, again, majority of the patients are above our range of potential injury, so the range that we're not happy with. So ideally, with this whole concept, we are fine with plateau pressures 28 to 30. And most recommendations are to keep it less than 30, and we agree with this limitation, this general limitation of minimizing plateau pressure, but anytime we can get less than 28, it is much more preferred. So I mentioned the one thing we were keeping on our registry form that we are performing and measuring in all of our COVID-19 patients is the recruitment to inflation ratio, which measures the potential for lung recruitment. And the first author is Dr. Liu Chen. He's one of our research fellows. And as you can see, there's many people that have been working and are involved in the Toronto Centre of Excellence that are on this publication. And Just to explain it briefly, because I will provide an entire talk to the CSRT about the recruitment to inflation ratio, because it's something we're actively doing or going to be using in a randomized control trial. So I'll do a presentation just on the randomized control trial so people can learn about it. But the one way to assess whether or not end expiratory lung volume increases when you increase PEEP is to do multiple pressure volume curves. So a pressure volume curve is a compliance curve. Okay, so with a compliance curve, when you map out a slow flow inflation curve which eliminates all resistive pressure, you can predict, for example, if I increase by so many centimeters of water, I could get so much change in volume. That's compliance, it's mils per centimeter of water. So anywhere along this, I can predict where my pressure and volume should be. So if you do another PV curve at a higher PEEP level, and your volumes are not in line with what was down here, this is considered the recruited volume. And what the RI ratio does is takes that recruited volume, divides it by the change in pressure, and you get the compliance of the recruited lung, and then we divide it by the baby lung compliance, which is the compliance of the lung at low PEEP, which again is represented by this curve here. So you take those two compliances and you divide them and you get a ratio. Again, as I mentioned, I'm going to do an entire talk about this for the CSRT coming up shortly. But let me just explain what we do with this information. So we don't do this. To get this information, we do a short, simple maneuver. This maneuver includes lowering the respiratory rate on the ventilator to 8 breaths per minute. We use volume assist control. So we have a set volume, an exhaled volume, a high PEEP, a low PEEP, and we measure plateau at the low PEEP level. And then we have a release volume. And with all that information, we plug it in here. High PEEP, low PEEP, set volume, tidal volume at high PEEP, the tidal volume from high to low. So we have to watch the ventilator so that when it transitions from this PEEP to this PEEP, we have to pay close attention to the volume that's released because it's usually much higher than what's being exhaled at the high PEEP. And then we plug the plateau at low PEEP, and then it gives us our RI ratio, which is also available on my calculator, rtmaven.com, and there's also videos at the bottom to see how we do the maneuver. But again, I'm going to give a full talk for the CSRT soon. So by putting all that information in there, again, what it's looking at is with that released volume, we know what's exhaled here. The predicted volume is based on the compliance curve, so we measure the compliance at low PEEP using the plateau and the set volume and the low PEEP. And so we know how much we should lose when you lower PEEP. So instead of going up and predicting, we're going down and predicting. And anything extra is the recruited volume. And this is the same recruited volume that you would notice if you were going up. So this was validated against those multiple PV curves, and this is what we use clinically at the bedside to determine whether or not, if there's potential to recruit a lung, we use higher PEEP. If there's no potential, we use lower PEEP. And the cutoff value is greater than or equal to 0.5 of this ratio, and that would indicate a patient who has more potential for recruitment. Now, the only issue with this is that if you had a patient that was 0.49, it's hard to argue that these patients are different. So it's a spectrum. The farther you are away from 0.5 going up, the more recruitable you are, and the lower you are away from 0.5, the less recruitable you are. So it takes a little bit of clinical judgment when you're right around 0.5. Now I'm going to explain the importance of assessing airway closure. So one thing I may have quickly mentioned, but you may have noticed on this recruitability or this RI ratio section of the registry form, is there's something called AOP, which is airway opening pressure. And sometimes I may use the term of airway closure because on the way up, it would be airway opening pressure. On the way down, it would be a closing pressure. But what they noticed is that when they were doing the PV curves, they noticed something that has been referred to for many years as the inflection point, because it is the inflection point. But how it's been interpreted is the point of recruitment. So what was a clever thing that Dr. Chen did was he put the compliance curve of a circuit that is completely occluded and mapped it over top. And what's interesting is up until this point, the pressure volume curve of the patient is exactly the same as an occluded circuit. So at this point, it opens and it's now inflating the lung. So this is very important because if you're expecting when we do the simplified maneuver where we drop the PEEP by 10, if partway down there's airway closure, then the drop in pressure is not really 10 centimeters of water. In this example, it's 3.2 centimeters of water. So what we need to do is we need to assess this and then put the value in here, and then it compensates for that in this whole calculation. And that's the importance of measuring airway closure. Now, if your ventilator doesn't have a slow flow inflation curve, that's totally fine. There's a video on rtmaven.com website at the bottom that shows how you can do this maneuver on 2 different ventilators, and I'll add more as I get more ventilator videos. But basically you do a slow flow inflation curve. So this is 5 liters per minute of flow at a very slow respiratory rate. And you can see the pressure increases here, and then you have an inflection point. So this patient has airway closure. Most of the time, it would just go like this. Okay, so this is it's not normal to see airway closure. Airway closure is the abnormal, but we're assessing for it in case it exists. So we need to check for it. So we check for it every time before we do the calculation of the RI ratio. And then when you have this, you plug that number into the calculator. But a brief check to see whether or not it is closure. This is not part of the RI ratio, but if you take this pressure, so we went from 0 to 18 here. So the change in pressure is 18 centimeters of water. And the mils, when you put the cursor at the inflection, the mils are 45 mils. So when you take 45 and divide it by 18, you get 2.5 mils per centimeter water, which is the compliance of a circuit that is occluded. So circuit compliance when you occlude a circuit is between 2 and 3 mils per centimeter water. So the reason why this is important, you don't have to do this, but it helps you to confirm that this inflection is indeed due to just ventilating a circuit up until that point. But you do not need to put this into the calculator. You need to put this value right here into the calculator. Now, the first study to publish the use of the recruitment to inflation ratio looking at potential for lung recruitment in COVID-19 patients was just published recently in Critical Care Medicine. So in this study, Tommaso Mari and colleagues assessed 10 patients with COVID-19 at a PEEP of 5 and a PEEP of 15. They say in their paper that the majority of the patients, or the median RI ratio, suggested recruitability. So some of the patients wouldn't have been recruitable and some would have, and I kind of wish that they provided a little bit more data separating these 2 patients, but there may not have been enough because it's only 10 patients. But it would have been nice to see if they responded differently than the group as a whole, so looking at recruiters and non-recruiters. But overall, the PF ratio improved, which again would make sense in a patient that has recruitment potential because you increase PEEP, the PaO2 increases. But they also reported the CO2, which increases, and the ventilatory ratio, which significantly increases. And that's a marker of worsening dead space. So again, to add strength to the fact that we probably shouldn't focus just on PaO2 or FiO2 when setting PEEP. If we are worsening dead space, the patient is not better off just because their PaO2 is higher. And we need to consider more things. And again, keeping in mind that plateau pressure is still at a safe range, driving pressure still at a safe range, compliance reduced but not significantly. So there's really no indication that PEEP could be harmful in this patient unless you look specifically at how ventilation worsened when increasing PEEP. Now they were using 7.4 on average mils per kilo of tidal volume, which again is within the range of safe lung protective ventilation tidal volumes, but it is higher than 6 mils per kilo, and perhaps using 6 mils per kilo may have resulted in a different reaction when they increased PEEP, but I have a feeling this had to do with the increasing in PEEP rather than the tidal volume. Now, the ventilatory ratio comes from a paper published in the American Journal of Respiratory and Critical Care Medicine in 2019 by Sinha and colleagues, and they look at a ventilatory ratio of 2 or greater, and they show that in the combination of moderate and severe ARDS, or moderate ARDS alone and severe ARDS alone, you can see that there is a significant difference in the mortality between these patients when separated according to ventilatory ratio. So in all patients together, 34% mortality versus 51. In just moderate, it's 27 versus 40% mortality, and 46 versus 61 in the severe ARDS group, again, when separated according to the ventilatory ratio. So if we are manipulating the ventilator and worsening this ratio, perhaps we should consider some other strategy for managing these patients. Again, this is anecdotal, hypothetical, theory generating, or hypothesis generating, I should say, and therefore Again, I can't say that that's what we should do, but it's just another interesting value that we should probably just consider looking at least to see if the trends are making sense. If we see that every time we increase PEEP in a patient, this value gets worse and the patients get worse over time and they don't improve, again, it may just suggest some other marker of benefit or lack of benefit when adjusting PEEP. In a univariate analysis, it had quite the odds ratio of increased mortality, and when you combined it with all these other ones, also had an indication for higher mortality. You can see all the values are significant over here. And what's interesting is that a high ventilatory ratio, both in their primary study for validation and then looking at it as at another cohort, the high ventilatory ratio was associated with more time on the ventilator. So patients that had worse ventilator efficiency or ventilation efficiency ended up on the ventilator longer. Now, the next challenge after patients are managed acutely, of course, is weaning and liberation. So a measurement available on most modern ventilators to assess patient effort is something called the occlusion pressure, or P0.1 maneuver. Now, some ventilators will do this in real time and estimate it, so you have a constant readout of a value, or other ventilators will do a maneuver, and you have to do these manually, or you can set them to repeat every 5 minutes or 10 minutes, but it has a very short pause until the patient triggers, and then it releases the pause, but it's measuring the drop in pressure in the first 100 milliseconds of a breath. And then based on that, you have an indication of how strong the patient's effort is. So in terms of targets, -1 to 3.9 is a target we're going to be using in a randomized controlled trial. Ideally, we like the numbers to be between 2 and 4. We know the patients are doing work, but not excessive work. So although we like to keep it less than 4, or -4, some ventilators read it as a negative number, some ventilators read it as a change. So it could be a positive number. But in terms of the literature, many people agree that a P0.1 greater than or equal to 6 is considered excessive effort. And some of these COVID-19 patients, when they wake up, we are seeing P0.1 measurements up at 12 centimeters of water. So these patients, we try our best to reduce their drive. What can happen, however, if we can't reduce the drive, that in a couple of days the oxygenation requirements go up, the patients then get back on full ventilation, and they just have this difficulty weaning. Again, not all patients, but when they're having difficulty weaning, a lot of it is related to really high drive despite the type of support you're trying to give the patient. Another method for assessing effort, which is also an occlusion pressure, but not the P0.1, is this study that used an occlusion pressure to predict PMUS and dynamic transpulmonary pressure. And what's interesting, so this paper was published by Michel Bortoni and Ewan Gallagher and colleagues in Critical Care in 2019. And what they did is they did multiple occlusion maneuvers on the ventilator. And when you occlude the airway, the drop in pressure actually is the same delta pressure that would occur in the pleural space because you are blocking flow. So the pressure would reflect the same in the esophagus. But as soon as there's an occlusion or a plateau pressure, either at end inspiration or exhalation, it takes about 0.3 seconds for the brain to clue in. So when you occlude the airway, at end exhalation, and the patient makes an effort, they will almost immediately or very quickly increase their effort to try to pull in flow. So it does not reflect the spontaneous breathing that occurred prior to that. So what they found is that this value here, when multiplied by a fraction, can predict PMUS as well as dynamic transpulmonary pressure. And when PMUS is greater than 13 or dynamic transpulmonary pressure is greater than or equal to 16, they suggest perhaps closer monitoring of this effort using an esophageal pressure, or consider modifying sedation and ventilation to achieve predicted PMUS and dynamic transpulmonary pressure within acceptable limits. And then once you achieve that, the target is achieved. So this concept here has not been tested yet in a randomized controlled trial, but let's look out for work by this group in the future using this method, hopefully. And finally, how should one do a spontaneous breathing trial? Many people all over the world use different techniques for spontaneous breathing trials. I'm going to describe the technique used at all downtown academic centers in Toronto. So we have a standardized spontaneous breathing trial approach based on a lot of it based on the work done here by Michael Sklar. And the reason we do this is because we choose a method that best reflects the post-extubation work of breathing, and perhaps something to do in patients with COVID-19, considering we're hearing reports of many patients requiring reintubation. that perhaps we need to make sure we are giving a spontaneous breathing trial that best reflects the post-extubation worker breathing so we know whether or not these patients will tolerate it. So this table published in the paper describes the differences between the mean worker breathing, pressure time product, and rapid shallow breathing index, again, all surrogates for patient tolerance of a spontaneous breathing trial. They compared the work and these measurements being done on the technique for spontaneous breathing trial and then compared it to post-extubation. So I'm going to focus on the post-extubation ones here, 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 and here. The first one is pressure support versus extubation. So if you divide the two means of the work, if it crossed 1 or if they were the same, then you would have 1 when you divide the two values. So as you can see, these ones are way down here for pressure support versus extubation. So pressure support underestimates the worker breathing post-extubation. CPAP underestimates the worker breathing post-extubation. Let's skip to the end here to T-piece, because this is the traditional method of spontaneous breathing trials. T-piece slightly underestimates, but as you can see, it crosses 1 in a few of these values. So it's the closest so far to representing the post-extubation worker breathing. Now, the one that we utilize is pressure support 0 on 0. So ventilators tend to give bias flow and can generate maybe between 1 and 3 centimeters of water when a patient is on 0 support. And that very little minimal support, again, this is not with automatic tube compensation turned on. This is not compensating for any resistance, because when you pull the tube out, the patients will have to breathe against the resistance of a slightly swollen or more swollen airway. So this, again, pressure support with CPAP to 0. So 0 of pressure support, 0 of CPAP, this is called 0 on 0 with no automatic tube compensation, best reflects the post-extubation worker breathing of all these measurements. Again, the only other one that cross 1 is this one, but it's pressure support versus CPAP. So they both act the same, but again, we're looking at the ones that are post-extubation. So pressure support 0 with CPAP 0, post-extubation worker breathing is very similar. And this is the method that we use for all of our spontaneous breathing trials. And we do this for 2 minutes at first to check for tolerance. And if they pass the 2-minute screen with an RSBI, we use that for the screening tool. And then we continue on for 1 hour. So I want to now just mention the respiratory system mechanics calculator that I have online called rtmaven.com. It's free to use. Anyone can go to that website and it can be saved to your home screen on your mobile device. And it has a number of things here related to respiratory system mechanics. Again, using esophageal pressure. You can put in the patient's gender and height to get your ideal body weight. So your predicted body weight will be here. And then 4, 6, and 8 mils per kilo will also show up on the screen. The airway opening pressure and recruitability is something I've already talked about. The ventilatory ratio is on here. If you're doing diaphragm ultrasound, the diaphragm thickening fraction is there. And then the predicting effort, this is the FAARC maneuver I told you earlier, where you do an expiratory pause and it can predict PMUS and dynamic transpulmonary pressure. You can use the calculator for that as well. Again, free to use. I highly suggest checking it out. At the bottom of the page are videos on how to do these maneuvers so that you can view and watch how they're done. But again, I'm going to have a separate talk on the recruitment to inflation ratio and our upcoming study, the Caviards 19 study. And our Caviards 19 study is careful ventilation in COVID-19 induced ARDS. The control arm is going to be using high or low PEEP table. It's actually going to be dependent upon the institution and what PEEP table they want to use. Again, targeting 6 mLs per kilo, limiting plateau pressure. Again, so we have a bunch of guidance. If the plateau is greater than 30, we should reduce tidal volume, etc. We are going to control the patients for 48 hours and then allow spontaneous breathing after that. And then we're going to continue to monitor. And for the control arm, pressure support, 6 to 8 mils per kilo, typical management strategy. In the experimental arm, we're going to do full respiratory system mechanics. We're going to assess for airway opening pressure or airway closure, as I mentioned earlier. We're going to then set PEEP based on the recruitment potential. So those that are recruitable, we're going to set the PEEP at 15, and we will increase the PEEP provided the plateau pressure stays 28 to 30 at maximum, or driving pressure should not exceed 15 centimeters of water. Also, if it does, then we will keep the PEEP at 15, but reduce the tidal volume as mentioned here. For patients that are not recruitable, we would set the PEEP 8 to 12 or at the level of airway opening pressure if it exists. again targeting 6 mils per kilo of predicted body weight for all patients. And then same thing, after 48 hours of passive ventilation, we will allow pressure support breathing, but we are going to be monitoring the P0.1 and try to keep it between 1 and 3.9. I'm going to finish off this talk with just a few additional issues. First is dead space, and then the next one is humidification. So dead space in these patients has been described because of these microemboli that many people are reporting. And just to let you know, when patients require high minute ventilation, a considerable gain in alveolar ventilation can be achieved by removing the flex tube, also called the catheter mount on the inline suction catheters. And if you're using an HME, you can remove the HME. And by doing the combination of removing both of those, if you're using HMEs, you can improve alveolar ventilation by about 29%. So this is an important strategy when someone is having ventilation issues to remove any, again, additional mechanical dead space that exists in the circuit. Now, for institutions that are exclusively trying to use HME because they're worried about exposure of these patients, keep in mind that although HMEs can provide humidification, and could protect from a circuit disconnect if it was on the ventilator side. If it was disconnected at the endotracheal tube, it does not protect you from exposure. It does add anywhere from 30 to 90 mils of dead space depending on the filter you're using. It does require routine changing, which of course there's your potential for exposure because you have to change them routinely. And HMEs with viral filtration, depending on the brand, are sometimes less efficient at humidification, so this might be a problem. And there is potential for circuit occlusion at the patient connection due to mucus plugging if it exists, which has actually been reported in many patients with COVID-19 having thick secretions and even cast formation. Whereas heated humidification, we know provides effective humidity. There's no additional dead spaces added to the circuit, so that's a benefit. And it may provide more optimal humidification compared to HME viral filters, and which is important again when secretions are thick and tenacious, as I just mentioned. Some issues is that if you have a circuit disconnect, again on the ventilator side, there is no patient side. It's just if you have a disconnect at the patient, there's exposure. Your expiratory limbs, because there's no filter at the patient, then you need to have a viral filter between the circuit and the expiratory cassette, or again, the room essentially. We should also filter the inlet towards the patient. And if the expiratory cassette or block of the ventilator is not heated, filters may need to be changed due to condensation. Having said that, there is now a strong consensus for, again, countries that have been dealing with this longer than us. There's a strong consensus in Europe that we should be using wet and not dry circuits because many have reported issues with secretion management. So in summary, we do really feel that we should be treating patients individually based on their response to the therapy we're providing. Now, some things do not require treating differently, like for example, the use of tidal volume. 6 to 8 mils per kilogram should be the standard, not higher than that, because this is still considered lung protective ventilation to use between 6 and 8 mils per kilo. However, starting with 6 mils per kilo of predicted body weight is preferred, and only using 8 mils per kilogram if two conditions are met. One, the patient is hypercapnic and you need to blow off CO2 and you've already increased the respiratory rate. And secondly, your plateau pressure is still less than 30 when you increase the tidal volume. Now, early intubation when signs of increased effort are existing in patients that are hypoxemic is important rather than delaying and waiting for them to fail later. We will be stratifying PEEP by the RI ratio that I described, and we'll provide another full talk for the CSRT. The controversial recommendations out there are to treat these patients differently based on their compliance. Now, one paper and one talk by the European Society of Intensive Care Medicine suggested stratifying based on a compliance of 40 mils per centimeter of water, whereas another recent paper by Gattinoni suggested greater than 50. So again, this is anecdotal data. It seems to be shifting a little bit. Yes, they are suggesting stratifying based on respiratory system compliance, but the cutoff level is different depending on which paper you read, so please consider this a very anecdotal suggestion, but keeping in mind that if you had a patient with really high compliance, it's hard to think that that patient would have a lot of collapse on their lungs, so that is possible, but again, it's anecdotal. Assess the physiological response to PEEP, so when you increase PEEP, assess something else other than just PaO2. What's happening to the ventilatory ratio? Is their ventilation getting worse despite an improvement in oxygenation? And always keep your plateau pressure as low as possible 30 centimeters of water seems to be a reasonable upper target. Again, the safer it is would be based on how low it is. So of course, if you can limit to 28, that would be preferred, but the current recommendations allow up to 30 centimeters of water and suggest keeping it below that. Thank you so much for your time. I encourage you to check out our blog, coemv.ca, where we have a message to respiratory therapists, again, describing the methods that we are using to treat these patients, which are no different than treating our standard ARDS patients. You can also follow me on Twitter, and I also have a Facebook page. Thank you very much.